Coming back to the refractory seizures or super refractory seizures, the reason why they're difficult to treat is because after about 30 minutes of actively seizing, there's certain destruction of the neurons, and these destructed neurons release glutamate, which is again neuroexcitatory, and this causes still seizures, further seizures, and they cause further destruction of neurons. So this forms a continuous loop, and it's difficult to break this cycle. And that is why we want to sedate the patient and give them further anti-epileptic drugs to kind of break this cycle. So discussing about EEG as we promised, so electroencephalogram. So this involves 21 electrodes being placed at different parts on the scalp. The position of these 21 electrodes is depending on the lobes of the brain. There are two forehead electrodes which are placed, then the frontal electrodes, parietal, occipital, temporal electrodes, and there are few central electrodes which are like a reference point. These electrodes are numbered even and odd. So even is for the right side of the brain or the scalp, and the odd is for the left side of the scalp. And we obtain certain waveforms based on the electrical activity. And these waveforms are positive and negative deflection, similar to an ECG, but they're different in ECG from ECG because the negative wave is an upward deflection and the positive wave is a downward deflection. So if you see more number of spikes, the negative waves, and the normal EEG waves are alpha, beta, delta, and theta, and these are seen classically also in case of sleep studies. So in addition to EEG, we could do other studies combined with EEG, like electromyogram or electrooculogram, or ECG, and we could do continuous EEG or video EEG. These studies help in further information. For example, in case of electrooculogram, there's also movement of the eyelids or twitching of the eyelids, which is taken up as impulses, and that will help to see whether this is sort of the outcome with the electrical activity produced in the brain. In case of continuous EEG, it is helpful to see if we are doing burst suppression. So burst is sort of the active electrical activity going on when the person is in status epilepticus. So that's called burst waves. And when we want to sedate them and give them anti-epileptics as treatment of refractory seizures, we can do continuous EEG to see if we are able to suppress this burst waves, and that is called burst suppression. That is all for today. I hope we learned something about the seizures and how to manage it initially, and also new terms like status epilepticus, refractory seizures, super refractory seizures, and we know why seizures occur and how to tackle them. Other simple nuggets for further learning would be that if the patient is in super refractory status epilepticus, there are certain things called IV ketamine infusion to give them to reduce the seizures, which is NMDA receptor antagonist. Then there is also hypothermia, that is to cool the patient down to reduce the electrical activity in the brain. And there's another interesting treatments for focal seizures, which are refractory to medication as well. And this is done as outpatient after a lot of imaging and planning. This is deep brain stimulation. It's called as DBS, and the other thing would be vagus nerve stimulation. And maybe at some point we will come back to these procedures and have a look. All right, happy studying. Bye-bye.